Hi, everyone. Thanks for joining today. There are two things that I personally and truly enjoy in the Canadian healthcare system: universality and accessibility. So, if I get sick today, I am entitled, on uniform terms and conditions, to publicly funded health services covered by provincial plan. And in my case, it would be the OHIP. In other words, as a Canadian resident, I have free access to physicians and hospital services. However, despite this universal coverage, we've seen disparities in the access to healthcare services born out of several social determinants. But the good news is digital health, along with virtual care, has the potential to address some of the barriers to access. But the bad news is, at the same time, it can exacerbate the access divide and lead to more inequalities. Our performance analytics team at Canada Health Infoway collected data on Canadians' experience with digital health services on a yearly basis. And based on this data, we investigated the gaps in the access to and the use of digital health services. And today, I have the privilege to walk you through the second iteration of our digital health equity analysis. I'll start with the key findings, then present the context of the analysis and its objective. And to help you understand how the results have been generated, I'll present a summary of the methodology we adopted and the definitions of the key concepts. Then I'll dive into the results of the analysis. Three groups of equity factors were studied: health-related factors, socio-demographic, and socioeconomic factors. For the first group, variability in access to digital health services and virtual care use was found for access to health care provider, health coverage, and the presence of a chronic condition. For the second set of variables, variability was found across race and ethnicity, geographic location, and primary language spoken at home. And lastly, for the third group, unemployed Canadians reported the lowest proportion of people with access to digital health services, 47%, and the lowest average number of virtual care visits, 1.6. As you already know, there's been a surge in the use of virtual care during the pandemic. Our survey suggested that consumer adoption went from 10 to 15% in 2019 to more than 60% in 2020. We also found that Canadians reported a high propensity to use digital health services beyond COVID-19. At the same time, the pandemic has spurred an appetite for the collection of race-based and Indigenous identity data related health. Given this consumer adoption, the main objective pursued in this analysis is to try to understand how access to and utilization of digital health services varied across equity factors. And in a subsequent slide, I'll define what these equity factors are. But for now, let me say that these factors fall under three main categories. One, health status. Two, socio-demographic factors, and three, socioeconomic conditions. And separately, we will be looking at how these factors impact access to digital health services and virtual care utilization. To measure access, we directly asked Canadians during our National Citizen Survey whether they had access a list of digital health services. And for utilization, we collected the number of virtual visits they had in the past 12 months. In terms of methodology, we relied heavily on graphical and bivariate analysis. So The analysis sets out to be more descriptive in nature. And to define equity, we turn to the task team on equitable access to virtual care at Health Canada. But what I really want you to take away from this definition is that health inequities, which is the opposite of equity, go beyond the inequalities with respect to health determinants. They also involve access to resources needed to improve and maintain health and health outcomes. And this is where access to personal health information, digital health literacy, and access to health insurance coverage come into play. This slide shows the equity stratifiers. And according to Kai-Hai, an equity stratifier refers to a characteristic such as demographic, racial, economic, that is used to measure differences in healthcare across population subgroups. So the equity stratifiers considered in here, they conform with Kai-Hai's recommendations. Here we mapped out the 5 digital health services we considered. For example, we have eView personal health information, e-mental health services, video conferencing, and we bundle all these 5 in one single variable called access to at least one of these 5 digital health services. Now, let's dive into the results. We'll start with health-related factors and health inequalities. The chart on the left shows that patients with access to family doctor or a regular place of care were twice more likely to access at least one of the digital health services, and the largest gap was found for eView personal health information. Now, as you can see, we have a 15 percentage points difference for eView personal health information. And we all know that access to personal health information is important for patients so they can better manage their health more effectively. And at the same time, we know that access to a regular healthcare provider is crucial for continuity of care. And on the right, the results suggest that those with a regular healthcare provider, they reported a higher virtual care utilization, 2 visits on average, compared to those without a healthcare provider, a regular healthcare provider, only 1 visit on average. And these virtual visits, they can be conducted either through video conferencing, secure messaging, and phone consults. During the survey, we asked respondents to rate their physical and mental health. The idea in here is to see if digital health is not to see if digital health enhances health status. Instead, we try to understand if health status influences the decision to use digital means for better access to health. For physical health, for instance, those who rated their health poor, they were the most likely to use digital health services with 53%. And those with excellent physical health, they were the least likely to use digital health services, 45%. And then on the right, as we can see, those with the poor health status, they reported the largest number of virtual care visits compared to the others. And the small green bars that you see represent the proportions of total primary care visits conducted virtually. So the rationale behind this is to explore the extent to which people are willing to substitute in-person visits for virtual visits. And those with poor health, they showed the highest proportion. For mental health, overall, those with poor and fair mental health, these 2 subgroups, they reported the highest proportion for the use of digital health services, 52%. And then in terms of how they access these services, they were more likely to use free services with 60% if we look at the chart on the right. For chronic health conditions, access to digital health services is 1.5 more common among those with a chronic illness, 56% versus 44%. And similarly, on average, those with a chronic condition had more virtual care visits, 2.6 on average, relative to those with no chronic condition, to 1.1 visits on average. We dug a little deeper into the group with a chronic condition accessing digital health services. First, we found out that more than half of them are dealing with one chronic condition, and the other half have two chronic illnesses or more. Secondly, on the right, we've noticed a weak association, though statistically significant, between the number of chronic illnesses and the number of primary care conditions. For health coverage, those with no health coverage are twice less likely, with 35%, to access digital health services compared to those with a public or private health coverage. And similarly, if we look at on the right, they reported the lowest number of virtual care visits, only 1.1 on average, and the lowest proportion of primary care visits conducted virtually, only 32%. So bottom line, health coverage seemed to matter a great deal when it comes to accessing digital health services. Now, moving to socio-demographic factors and starting with gender identity. What we can say, no material differences were found across gender identity. However, men reported the lowest access rate with 45%, and the lowest average virtual care utilization with only 1.8 visits on average. For age category, across the access to digital health services were nearly similar across age categories with tiny differences across the age groups. But millennials reported the highest access rate, 53%, and the highest average virtual care utilization rate with 2.2 visits on average. But one thing to highlight is that senior Canadians are among those are among the higher users of digital health services and virtual care, with 51% and 1.8 visits on average. And I think these results, they are consistent with the with a recent analysis that was conducted by the Women's College Hospital. Now, for race and ethnicity, some differences in access to digital health services were found across race and ethnicity. Indigenous peoples and Black African Canadian descent, they reported the lowest access to digital health services, 47% and 44% respectively. We've seen variability for almost all the digital health services, except for video. If we look at the red dots, we didn't see much variability for video conferencing, or it was minimal. Nonetheless, in terms of virtual care utilization, Indigenous peoples and Black African Canadian descent, they were among the high virtual care users with averages greater than 2.7 for Indigenous people, average number of primary care visits, virtual primary visits. And then for Black and African Canadian descent, we have 2.1 visits on average. But I have to clarify that we used an online panel and a web survey. Thereby, Indigenous peoples living on reserve might be underrepresented in our sample. And on the right, we have the modalities used across race and ethnicity for virtual care visits. Phone, as you can see, is the most used regardless of the race and ethnicity. For geographic location, access to digital health services was higher among urban Canadians than it was for rural and remote populations. However, those in remote regions, they reported the highest average number of virtual care visits, 2 visits on average. Now, moving to immigration status. For immigration status, the immigration status didn't seem to matter a lot when it comes to accessing digital health services or using virtual care. The differences among immigrants and non-immigrants were very marginal, as we can see on the left. And on the right, they have similar averages, 1.9. However, within the immigrant group, those who've been in Canada for 3 years and less reported the highest proportion for access to digital health services, but the lowest number of virtual care visits on average, 1.5. For primary language spoken at home, Canadians whose primary language is English showed the highest proportion of people, 50%, with access to digital health services and the highest average virtual care utilization rate, 2.1 visits on average. Moving to socioeconomic factors and looking at how these factors impact digital health inequalities. And for these factors, we collected 2 stratifiers. We collected information for 2 sub-factors, employment status and income. For employment status, unemployed Canadians, they showed or they reported the lowest proportion of people with access to digital health services, 47%, and the lowest average number of virtual care visits, only 1.6. We are looking on the right, the chart on the right, 1.6 visits on average. And lastly, for household income, the proportion of Canadians accessing digital health services seemed to increase with household income, as we can see in here, 43% for low income, 51% of medium income, and those falling in the high income bracket, they have 55% access. And in terms of the average number of virtual care visits, we've seen the same scenario. We've seen an increase. It increases with the income, with household income. So those with low income have an average number of virtual visits, 1.7, medium income, 1.9. And lastly, those with high income, they had an average number of virtual visits of 2.1 visits. Some limitations are worth mentioning. There are some factors that may amplify inequalities that were left out in our analysis, notably digital and structural factors. For example, broadband penetration, internet speed, policies. In addition, our analysis hinges heavily on bivariate analysis. Thereby, this limited our ability to explore intersectionality or the complex interaction between the different social determinants we have considered. In conclusion, universality and accessibility are the 2 tenets that matter the most when it comes to digital health and virtual care. So digital health and virtual care can help to mitigate existing health inequalities born out of social determinants by improving access to health services and thereby build the foundation to address inequity in treatment and health outcomes. At Canada Health Infoway, we will continue to explore how the equity factors impact access to digital health services, and we are open to partnering and collaborating with others in order to address inequities in the delivery of healthcare in Canada. Thank you for your attention.